Good evening, everyone. My name is Zahra Akbar. I'm an R2 OBGYN resident in the Kuwaiti board. Welcome back, everyone. I hope you enjoyed the break that you had lately. We're returning again in 2021 with new topics, new ideas, and hopefully that will benefit you in your clinical activities. Today, we will be having a review about trauma in pregnancy, which will be presented by two speakers, Dr. Saud Zaid and Dr. Jihad Al-Harami. Dr. Saud Zaid, he is a trauma surgeon and critical care specialist in Jabir Al-Ahmed Hospital. He's an instructor in multiple different trauma and resuscitation programs and courses. He's an assistant professor in surgery at the Faculty of Medicine. And previously, he was a trauma director at Adan Hospital. And currently, he's working in the COVID-19 ICU in Jabir Al-Ahmed Hospital. His areas of interest are critical care and trauma development, global surgery and community outreach, resuscitation and shock physiology, damage control and field surgery, and combat sports. During his days off, he loves barbecuing and practicing Brazilian Jiu-Jitsu. Dr. Saud Zaid today will be talking about trauma in pregnancy. And then we will move to Dr. Jihad Al-Harami, who is an assistant professor in the Department of Obstetrics and Gynecology in the Faculty of Medicine of Kuwait University. And she's a consultant of obstetrics and gynecology in the maternity hospital. Dr. Jihad graduated from the Faculty of Medicine with a degree of Bachelor of Basic Medical Sciences in 1985. This was followed by a degree of Bachelor of Medicine and Surgery in 1987. She obtained a clinical fellowship in obstetrics and gynecology from McGill University in 1997, and she was awarded the fellowship of the Royal College of Physicians and Surgeons of Canada in obstetrics and gynecology. She held the position of Deputy Director of the Postgrad Residency Program in KIMS from 2000 until 2010, and she held the position of the Chairperson of the Department of Obstetrics and Gynecology in the Maternity Hospital from 2008 until 2010. During the same time, she served as the Chairperson of Obstetrics and Gynecology Council in the Ministry of Health. She is a surveyor for the National Accreditation Program in the Ministry of Health and Accreditation Canada International. She held the position of acting chairperson of the Department of Obstetrics and Gynecology in the Faculty of Medicine. Her areas of expertise are obstetrics and gynecology, medical education, evidence-based medicine and critical appraisal, accreditation, risk management, patient safety, and quality improvement. And she will be talking about perimortem cesarean section. So first we will start with Dr. Saud Zaid, and then we will move to Dr. Jihad. And finally, at the end of the session, we will have 15 minutes for questions during the discussion period. So first, we will start with Dr. Saud. Dr. Saud, you can start.
Okay, thank you for that very flattering introduction. Thank you for inviting me here. It gives me great pleasure to be able to talk about a topic that I find very ridiculously interesting, trauma, and obviously resuscitation in general. From the outset, we need to understand the facts of the situation that we're in, okay? 3 to 6% of all trauma ER arrivals in most trauma centers will be pregnant. That's 1 in 20. So if you work in an emergency room, or if you're a trauma surgeon, or a surgeon responsible for trauma, 1 in 20. 1 in 20. So it's a big number. I can tell you at Adan Hospital, we had about 100 or so, 150 over the course of a year, give or take, right? Depending on what year you looked at and things like that. It involves about 5 to 20% of pregnancies. For the most part, if you're going to experience trauma, it's going to be an MVC in your 3rd trimester, okay? It's rare in the 1st trimester. It's more common in the 2nd, but by and large, 50% of the time or so, depending on where you read and where you live, and what the MVC statistics are and things like that, it's going to happen in the 3rd trimester. MVCs are the most common cause. Motor vehicle crashes are the most common cause, followed by falls, followed by assaults, and then burns being the least common. It is an unfortunate thing that assaults do occur, but they do occur, and the vast majority in pregnancy are penetrating assaults. You need to understand 20 to 60%, depending on where you live, of non-obstetrical causes of maternal death will be because somebody was attacked. A pregnant woman was attacked. This needs to be processed and understood. These statistics aren't made up. They're in most textbooks, and this is from Mattox, which is the trauma guidebook. Basically, it's the #1 trauma textbook. Fetal death is extremely low. It's extremely low, considering what the burden of trauma is. If I were to put up a pictogram, I would make it look like this, for you to understand the injury mechanisms and their impact. The causes of death are the bigger circle. The statistics are inside of them. Penetrating injuries are the most common cause of death, mainly fetal, but also maternal. It's quite significant, and this needs to be understood. This needs to be understood and processed. This is an extremely important issue, and it affects us all. Now, being a person who I usually gear my talks towards surgery, sometimes emergency medicine, sometimes ICU, sometimes international faculty at courses and things like that. In courses, it's a little bit easier. Trauma and pregnancy is taught in a very, very succinct way, where it's basically resuscitation, a little bit of jabber about that. The resuscitation leads to ABCDEs, which then leads to talk about shock and things like that and when to give blood. A little bit of how to intubate somebody with a burp maneuver so they don't aspirate, the maternal monitoring, transfusion science, here and there, but we always forget it as surgeons, right? I know that obstetricians are much better at it than I am. And then a little bit about damage control towards the end, and some fetal-maternal monitoring discussion that happens somewhere in there. That's what sort of happens in general. And I think that if I did that in 2021 through a Zoom meeting, this is what it would sound like. It would just be blah, 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 and you guys would be asleep, okay? I don't think that that's what I would like to do for you today. I think that today our goals should be, and we should look at goals and not objectives, because goals are something to strive for over time. And I'd encourage you to sit down and read around these topics because it's extremely interesting and extremely important. The mindset that you need if you're interested in trauma or acute care or time-sensitive disease, the milestones that you're going to go through and should expect, especially if you end up doing a trauma rotation somewhere, which I think everybody should do. It's a very life-changing thing. It changes your level of maturity, as you'll see, and what it means to be an expert, because I hear a lot of people tell me that they're experts, and I'm not sure how I feel about that. I don't consider myself an expert. I consider myself on a journey of expertise. Maybe it's because I have more than one field that I sort of jump between every now and then. As you clearly see, I'm currently in Jabal and I'm on call. But I don't really think that expertise should be considered a definition so much as a responsibility put upon you. And that's why whenever I talk to my residents when I'm teaching trauma, I give them belt rankings, and it's half joking, but this is the science behind it. This is not the science, but what I mean when I say you're a white belt versus a black belt versus something like this. As Zahra said, I'm a big fan of Brazilian Jiu-Jitsu and martial arts in general, and I like combat sports injuries. It's my area of interest. In combat sports, they have a belt ranking system for number one, safety, which is extremely important. Number two, so that you know where you are on your journey as you mature. Because a lot of the time we lose sight of this, especially as residents. You have hard years, you have easy years, you have tough days, and you just don't feel confident enough. And a belt ranking system helps you, in my opinion. And that's what I do with my residents when they rotate with me. As a white belt, I only want you to be in the resuscitation room and note the findings for your primary survey and secondary survey, mainly the primary survey. The secondary survey is really your exposure of the primary survey. But it's a bit complicated, depending on whether you do ATLS or ATAC or other resuscitation courses. That's all I need from you as a white belt. Some of them do develop an excellent expertise at performing procedures. That's profoundly amazing. Like I've seen R1s or even trainees end up putting in chest tubes in gynae or from a pediatrics background because they're interested, right? And when I see it, it's extremely, extremely impressive. They're super slicked. Blue belts, I expect by the end of your blue belt level, you should be able to act upon the findings that you see 100% of the time. By act, I don't mean put the chest tube. I mean recognize that you may not know how to put the chest tube yet because you haven't been exposed to it, because you were working in a different place where chest tubes aren't put in by general surgeons or are put in by general surgeons or something of that nature. And you just didn't get the chance. But you know who to call to help you. That's what I mean. You develop and establish attentive safety. The journey through Blue Belt is for you to become a safe practitioner in trauma, no matter what you see. Purple Belts decide and activate disposition. By disposition, I mean the patient's destination, and kind of know the plan that the consultant is going to use 50% of the time, maybe 60, 70 for the slicker guys. I've seen some slick purple belts. Brown belts decide and activate this position 90% of the time. And 90% of the things that a consultant would say, they already know what to do. And they're phenomenal. And they're slick technically because they already went through, they're like the equivalent of an R3 or an R4. They're very slick technically. Their decision-making requires some time. But they're learning how to call outside their expertise and be very good at it. Very good at it. And it's amazing when you see a good brown belt. Because, man, when they operate with you, you'd better hope that you've had your coffee. They're just as slick as you are. It's phenomenal when you see it, right? Black belts. 3 things. First, you need to be able to educate and train. Second, you need to be able to establish and run a program. Third, you need to be able to adequately find your deficiencies and integrate people, either by bringing people around you or extending your training, so that you have the answer 100% of the time, so that there are no preventable trauma deaths. Now, red and black belts, red belts, ask me in 2050. I don't think I'll ever get there, but if I ever do, I'll let you know. If I were to equate this to a residency program, whether you're doing emergency medicine, anesthesia, ICU, or orthopedics or general surgery. So in different countries, different people integrate into trauma, but no matter what you're doing. White belt is usually a trainee to an R1. R1 to R2 early, R3 is blue belt. Okay. Purple belt, R3 to R4. Sometimes it's an R5 when they haven't been exposed enough. Sometimes R5s still need some time. By the time you get your FRCSC, you should at minimum be a brown belt. And in my opinion, a trauma fellowship extends you from being the person who can operate most of the time and can handle most traumas, just like any other general surgeon, I want to say, or resuscitationist in the ER, whether it's ICU or emergency medicine, or even other people of that nature. Obviously, obstetrics and gynecology, it's not within your comfort zone. You're much better at other acute time-sensitive things like fetal distress, postpartum hemorrhage situations, bleeding that I can't control in the pelvis, quite frankly, sometimes. I've seen really, really strange bleeding happening in obstetrics that I personally find extremely challenging. And I see how calm you guys are. But I don't think that trauma is going to be a big part of your practice in general, unless you're a fetal maternal specialist, right? It takes about 2 to 15 years once you have independent practice to begin to understand that expertise is a journey. You're going to have challenges. You're going to have good days and bad days, and you're going to need to fill in your gaps, and you're going to need to establish partnerships that lead to expertise. Okay? I'd say a coral belt or a red and black belt is a trauma director. And the red belt is a policymaker. It's the person who writes the book. And I've met a couple of red belts. You don't want to meet red belts. They're super slick, they're super smart, but they're extremely humble too, because they know that they're also on a journey that I will never understand. Now, let's look at white belt level minimum requirements. My minimum requirements at white belt level are that you are able to assess an airway, assess a level of consciousness, put a C-collar on for airway assessment. Breathing, to auscultate bilaterally, check for subcutaneous emphysema, check for any bruising, any indications that there might be a pneumothorax or a hemothorax. Circulation, to be able to do a fast ultrasound to assess for abdominal injury. And by the way, most obstetricians that I've worked with, extremely good. Most obstetric residents that rotate with us in trauma, ultrasounds like this for them. They use buttons that I don't know on the ultrasound machine, right? Apply tourniquets accordingly and assess the hemorrhage and the stability of the patient, whether or not the patient requires any further resuscitation, and calling for help at that point. With disability, I expect them to get a gross examination for neurovascular injury, looking at the pulses, palpating the area and things like that. For exposure, log rolling and a secondary survey, as well as an ample history. That's all that's expected of you at white belt. That's an abbreviation of ATLS or other resuscitation programs, but that's all expected of you, and to know when to call for help. From blue belt onwards, you're not going to think like this anymore. You're not. You're going to understand the concepts in resuscitation. You're going to understand why I'm looking at the airway, breathing, circulation, why they come in first, why this patient needs to leave here in an hour. They can't spend more than an hour in the resuscitation room. And believe me, it's been studied. Even in major trauma centers, some really good trauma centers, patients will spend up to 2 hours in the resuscitation room simply because you're calling other services and there's some organizational issue or the patient's too unstable to move, and decisions have to be made. So you need to assess why we do A, B, C, D, E, F in that manner, and that my time limit to get angry at you is an hour, right, as trauma team leader. The reason why is 50% of your patients, if you don't make a decision within an hour, will die. And their causes of death, for the most part, will be airway, blood loss, and then neurological outcomes. Neurological outcomes, some people would argue still in the European literature that they're not preventable. In our literature, or the literature in the centers where I trained in, we're very aggressive about dealing with neurological outcomes as well. I think I talked about it before on this very forum. And if you want, you can look back on them. They're available on the podcast for the forum. That's why we do these things. And then you need to ask yourself, what do I need to think about with airway? So there's only one question that you need to ask yourself with airway. Only one. Because at this level, you've seen 15, 16, 17, 18, 20 traumas. You've passed your ATLS. Because as an R1, you have to do ATLS. In my opinion, you have to do it, even if you buy it yourself. Okay? It's life-saving. I think everybody should do ATLS. Medicine, surgery, even psychiatry. It's just life-saving. All right? And it's been studied. The more people have ATLS within a healthcare system, the better the outcomes. It's been studied. The only question that you need to ask yourself is, do I need to intubate? Because at this point, as a blue belt, you already know to assess the GCS, the level of consciousness, whether there's an obstruction of the airway, a broken mandible, craniofacial injury. You've already assessed these things. You've done it 100 times. You've done it so many times, it's like washing your face in the morning. You don't even think about it. So that's the question that comes up in your head, right? Your spider sense is going to be, do I need to intubate? Then it becomes breathing. For breathing, do I need the chest tube? Technically, if you have lung contusions, you can make the argument, it's also, do I need to intubate? Then it comes to circulation. And in circulation, it's a little bit more varied because you're going to think about what venous access do I need? Typically 2 large bore IVs in most current ATLS-based resuscitation programs. Is there any area of bleeding? Sorry, I was typing this half asleep. It's supposed to be, is there any area of bleeding? I apologize. And if there is, do I need to give blood? Followed by disability, looking for neurological injuries, both central and peripheral, as well as vascular injuries, assessing pulses. When you assess these things, as a white belt, you're going to assess area of dermatome. As a blue belt, you're going to ask the patient to squeeze their fingers, move their hands, and you're going to know. And you're going to do a rectal exam to check for anal tone, and you're going to go, boom, I know what I'm dealing with here. It's a spinal cord problem. That's why the patient's hypotensive. You're going to be that slick by the end of your blue belt. Then there's the exposure. The exposure, you're answering one thing. Have I missed anything? Once you're done with that, typically as an R2 or an R3, you're going to call somebody more senior, such as the senior registrar on call or the trauma team leader on call, depending on where you work. This person is typically a purple belt. Now, the most dangerous person in the hospital is the R2 to R3, in my opinion, and I'll tell you why. R2s and R3s already know what this guy's going to say or this person's going to say. Guy or girl or person. They already know what this person's going to say. They know that this person's going to tell them something, something, something. 50% of the time, this person's going to be right, at least 50% of the time. Some of them even more. This person in his head, the new skill that you get to elevate you to a very good purple belt is, where do I go next? Purple belts go beyond the golden hour. They recognize the other 30% that we're not seeing right over here, right? So we talked about why ABCDs are important and why being a slick blue belt will save lives, right? Mastering ATLS, knowing the concepts. Do I need to intubate? Do I need a chest tube? Do I need central access? Where am I bleeding from? And do I need to give blood and tranexamic acid? Boom. That's first thing. Purple belts know this part, the 30%. The 30% are divided into 3 different groups, typically. There are only 3 ways that this can go. Stable, unstable, or agonal, dying, okay? Stable patients, only 5 different destinations. Very rarely is it 5, it's usually a combination of them. 1, they can go home. So no seatbelt injury, nothing, low velocity injury, GCS 15/15, fast chest X-ray are negative, they're observed. 2 hemoglobins are fine. Neck is cleared. There's no indication for them to stay. They've been assessed by all other services in the emergency room. There's no causality established, like a medical cause for the RTA, such as a seizure. They're going to go, or MVC, such as a seizure. They're going to go home, right? CT scan or other imaging. And more increasingly in level 1 trauma centers, we do a lot of imaging. I can talk every day about PAT scans. There's a very good reason for them. okay? It's to avoid missed injuries. Then there's angiography, which is extremely rare without a CT scan, the ward or the ICU for a monitored setting, depending on their stability and the nature of their injury. Now you're gonna say, if they're stable, why do they go to the ICU? Because they may have a high-grade, high-impact splenic injury. They may have at-risk lung contusions, for which you might intervene later. That's why there's a 30% mortality associated traditionally. This number is improving with ATLS and with people being more cognizant of trauma in the mindset. The second situation that a purple belt recognizes is instability. Now, instability is a sliding scale, especially in obstetrics and gynecology, which I'll get to very soon, I promise you. This whole talk is going to be done very, very quickly, I promise you. Instability means you need to figure out one thing and one thing only, which compartment I'm going to open in the operating room. Now, instability doesn't happen suddenly. Your patient doesn't get better with blood. The numbers are still bad. The patient is still hypotensive. The lactate is still high. The base deficit is still high. The intensivist is very scared because you're telling them something and they're seeing that this guy's not gonna, you need to figure it out. The stab wound is still not so great. There's pulsatile bleeding from it, right, in the neck or something. Those situations you need to evaluate using a fast x-rays, chest x-ray, x-ray pelvis, to figure out which compartment you're gonna go into. If it's the pelvis because of a fracture, it's preperitoneal packing, plus or minus an X-lab. If it's fast positive, laparotomy. If it's fast negative, then you're going to have to think about other sources such as neurogenic shock, retroperitoneal hematomas. But you may have to go to the operating room, as well as obvious injuries to the chest, hemothoraces, okay? Now, if you have an agonal patient, what I've noticed is, in most places where trauma surgeons aren't available, the agonal patient gets treated like an unstable patient. The agonal patient is heart rate of less than 30 or 130 with a systolic of 60. You cannot perfuse your heart after a systolic of 60. It is physiologically impossible. It's been studied on multiple mammals. It is impossible for you to sustain a systolic of 60. Do not try. This is go time. This is the time that you're going to do an ED thoracotomy. And I will gladly go through chest injuries with you guys. I have an excellent talk with a bunch of real cases. The patients consented for them, just like the brain trauma talk. Now, in particular point for obstetrics, which Dr. Jihad has volunteered to talk about because I find it very challenging personally, and I'd like to thank her for it, is the perimortem cesarean section. I will touch on it for a second at black belt level for 1 second, but I'm not the expert at it, so don't ask me, okay? You need to be able to figure out how to go from a systolic of 60 to delivering the baby, then clamping the aorta, particularly for obstetrics here, okay? Then you need to move to the operating room because there's a reason why the systolic is 60. And in 100% of the time, it's hemorrhagic shock in pregnant traumas. It's actually been studied. Perimortem traumatic cesareans are underappreciated in the literature, but when you look at the fine print, they all have hemorrhagic shock. That's the reason why you did the perimortem cesarean, and they all end up with laparotomies afterwards, okay, if they're perimortem. Now, when you move to the OR, you know that you're going to do a laparotomy and you know that you're going to need some help, like orthopedics with you, because there's associated injury of the long bone 20% of the time. I have to be honest, purple belts will never be perfect at this, but you will begin to understand that learning how to deal with complex trauma is a lifelong journey. And this is when you start to like it. In my opinion, everybody should reach blue belt. I think everybody should at least reach a blue belt level of understanding of the situation, okay, in my opinion. But at a higher level, you may develop a passion for it. You may want to explore this. And that's when you know how to go beyond the golden hour, okay? Brown belts decide to activate disposition plan 90% of the time. So brown belts are more advanced purple belts in terms of what you see on the outside, the phenotype. But the cognitive aspect, the thing going on up here, different. They know when to call outside expertise. They're safer purple belts. They're safer than blue belts. They're safe people, and they're super slick when you see them. Their technical ability is excellent. They are almost always all-rounders. Tactically, however, their decision-making intraoperatively and outside the operating room is what they're working on at this time period, okay? There's oftentimes multiple things to work on and multiple gaps. The first is surprises. They're surprised that the patient suddenly became hypotensive. Black belts don't do that. They know that they're going to become hypotensive, right? Failure to recognize certain injury patterns. They don't know that if a patient's traveling at a certain speed, they're likely to have a problem in their spleen with some type of injury. A seatbelt injury is likely to have a bowel injury. They don't see that as much as black belts do. They don't see what's going to happen. Then there's delays in decision-making, which are extremely difficult to handle. You take longer to make the decision than a black belt would. You give the patient a chance, meaning you're trying to figure out. Now, as you transition as a brown belt, you realize that diagnosis has nothing to do with anything. You're going to be very good at guidelines. You're going to know your institution very well, the hospital that you work in very well. You know that blood takes a long time to get, so know to order it a little bit earlier, right? You're going to know that there are mechanisms of injury, and you're going to have a very robust understanding of anatomy and physiology. Those four things you're going to be very good at, but you're going to need to integrate the anatomy and the physiology with the mechanism of injury to produce a pattern of injury that predicts the injury. And then you're going to learn to integrate the guidelines and the literature with your institutional limitations. What works? Which guidelines are going to work for you in Kuwait? Not every guideline will work here. I can't get an MRI of the neck at 4 a.m. I just can't. Right? We know this, right? Then decision-making process. What options do I have and how do I activate them? And that's how you produce better patient outcomes. As a brown belt, you recognize that. This is when I'm going to transition to a very focused talk for about 10 slides or so, and then hopefully we'll be done, I promise. You have to understand, when you're dealing with pregnant patients, by and large, as a brown belt, you will recognize that you have an increasing size problem and you have a buoyancy problem. Imagine that your uterus becomes an airbag for the solid organs in the abdomen. That's what's really happening. And the diaphragm elevates, so breathing becomes more of a problem and the reserve goes down. At the same time, because of IVC obstruction, things like a CVP are unreliable. Venous return is unreliable to dictate how much blood is circulating, the circulating blood volume. It becomes unreliable. In addition to that, the placenta doesn't really help you that much for two reasons. The first is the placenta is rich in tissue factor, so it increases coagulopathy to an extent, physiologically. The second is 20% of your cardiac output, 20% of what you see in the cardiac monitor, the blood pressure, surrogate marker, I know, not accurate, 20% of that is going to the baby. As the systolic drops, the amount of cardiac output that goes to the baby goes up first and then goes back down. At least that's my understanding. Maybe Dr. Jihad can help me out a little bit. If your blood volume decreases by 30%, the uterine blood flow drops by 20%. That's a significant amount in a fetus. A 20% drop in blood flow is a 20% drop in oxygen exchange, is a 20% increase in CO2 accumulation to an extent, lactate accumulation to an extent, right? Any pressure drop in CO2 is compounded in the fetus. These are big things. These aren't small things, okay? And they have ramifications. And that's why it's very important to develop an understanding of the situation. Throughout pregnancy, this dynamic that I described changes over time, okay? The fetus during conception, the first trimester, it's a viability question. So it's very rare that we're going to be very worried. They're either going to survive to term or not. By the third trimester, the fetus is your compounding factor. It makes your physiology harder to deal with because there are three things. Like I said, the cardiac output situation, 20%, the oxygen exchange problem also occurs, and fetal consumption of oxygen. So the fetus will actually preferentially take oxygen from the mother, doesn't really decrease until the delivery of oxygen is reduced by 50%. So the fetus will preferentially take oxygen from the mother until the point where you can't deliver oxygen to the mother. You really have to understand that concept. And it's very hard to wrap your head around. That's why it's a brown belt level concept, okay? By 34 weeks, the uterus and fetus become like an airbag. I'm sorry to say it in that manner, but it is, in terms of trauma kinematics, that's what it really is. And they protect the solid organs more. In the first trimester, solid organ injuries are the same as non-pregnant, so are fractures. In the second and third trimester, there are two things. First, it's because of the momentum of the fetus and the mother as the weight and the weight distribution changes, leads to more pressure on the pelvis and the uterus and less pressure on the spleen solid organs and small bowel. And so you get a lot more placental abruption, a lot more retroperitoneal injuries, a lot more splenic injuries, a lot more pelvic fractures, a lot more uterine rupture, and a lot more abruptio placentae. okay? Small bowel, general surgery, catastrophes, much less. Kidney injuries, much less because of the uterus. It's unfortunate for the fetus, but the mother suffers from them much less. CPR is considered to be best supine if it's a primary cardiac arrest and you're not sure what's going on, simply to adjust things. And then you should elevate by 30 degrees to offset the IVC obstruction, because that will improve your cardiac output and will improve your fetal flow. It will compensate for whatever blood loss you have, particularly for us with hemorrhagic shock. You really have to understand, once you start CPR, you have 5 minutes to deliver the baby, to have an extremely viable fetus. If you wait another 5 minutes, if you hit the 11-minute mark, you're down to 13% from 70%. And that's unacceptable. It's hard, but it's unacceptable. When you talk about mortality and trauma, the overall fetal loss rate is 5 to 15%. Most of the time, it's associated with maternal shock. Most of the time, it's associated with a pelvic fracture or solid organ injury in the abdomen. Maternal mortality is associated with penetrating trauma and burns mainly. Penetrating trauma in particular is a bit of a problem. Penetrating trauma in particular is an extreme problem. And I think that when you look at the literature, it's also because we tend to try and conserve on them, and maybe we shouldn't. I personally am very aggressive about it. I do diagnostic laparoscopy liberally on pregnant women because I think that it's too risky to wait. And if I see fascial penetration and blood in the pelvis, I do a laparotomy. I don't wait. The risk factors for fetal loss, you need to know, because these are the things that are getting your spider senses tingling for either a high risk early cesarean or delivery rather, or a perimortem one. Motorcycle crashes, uterine ruptures, obviously, a rupture placentae, obviously. Maternal pelvic fractures, very much associated with premature labor and with fetal loss. Ejections. Ejections are actually almost like pathognomonic for fetal loss, which tells you that it's a high velocity thing, so more than likely there's multiple injuries going on. A high ISS score and maternal hypotension that is resistant. Very important to know. The same ATLS principles apply here. Nothing changes. The key difference is, even when you're putting in chest tubes, a brown belt recognizes to get it in the right place, I have to go up by an extra 2 to 3 levels. And if I'm going to do a DPL, it's better to be super umbilical and to palpate the uterus first. I'm oftentimes asked by general surgeons about fetal monitoring. Don't ask me to interpret this. I don't know how to interpret it. I have experts around, I'm lucky. Obstetrics is not my strong suit. Trauma is where I live. ICU is Hello? Can you guys hear me?
Yes, Doctor, we can hear you.
All right, I got cut off. The main reason as described to me is to check for viability and to check if the patient is in active labor, and sometimes, or very rarely, to make a perimortem assessment. My understanding is number 4 doesn't really happen anymore. And number 1 does happen more and more in associated biophysical profile, in association with biophysical profile. CTG monitoring, from my understanding at least, and maybe the guidelines have changed because it's been a year since I've seen them, is 100% sensitive and specific. With 4 hours, it's more than enough for a rupture placentae. However, it is also used for 4 hours to detect whether or not to extend for 24 hours. Associated reasons to spend 24 hours of monitoring is uterine tenderness, significant abdominal pain, vaginal bleeding, obviously, contraction frequencies increasing, for sure, rupture of membranes, atypical or abnormal fetal heart rates, high-risk mechanisms of injury, and serum fibrinogen levels greater than 200. Those are my understanding are the main reasons for fetal monitoring during trauma. In terms of the imaging, this is one of the things that turns me into a very stressed out and angry person. There is so much cartoony theories around. And when you look at the guidelines, the lifetime cancer risk of prenatal exposure is considered to be similar to that of exposure during childhood. So doing a CT perinatally or doing a CT during childhood, same, more or less. Perinatal exposures of 5 rods or less in a lifetime risk of cancer was less than 2%, 0.6% childhood. It's painful that there's a publication that came out of Kuwait saying that we have a radiation risk with these things. That's painful to me. It's unfortunate. If you did everything on that list, which we don't do in trauma, typically in trauma, we'll do a CT brain, maybe a CT abdomen, and a chest. But if you did everything on that list, including a check cholecystostomy, you would barely hit 5 rads, because this list is a millirads. If I did all of these things for a pregnant woman, I would barely have a lifetime risk of cancer. And the risks of premature labor just don't exist. And unfortunately, we've had patients that have had to go into crash laparotomy situations because of this reluctance on the part of various different teams involved with the patient's care, trying to be politically correct. All right, it annoys me. Radiographic studies are advocated for and indicated in most obstetric and gynecology guidelines. This is copied and pasted off of them. I'm plagiarizing, but it's for a good reason. There isn't enough data to tell me that this is the wrong thing to do for a patient. There is enough data to tell me that gadolinium is not the right thing to do, which is ironic that sometimes people suggest that an MRI should be used, which I think it does not make sense to me. MRIs oftentimes underestimate the grade severity of injuries, okay? Abdominal CT can and should be done. For us in trauma, in our assessment of the situation, 5 rads is the same number, and we do not recommend MRI. So, as a brown belt, you should recognize mechanisms of injury. You should recognize specific physiological principles involved in the pregnant patient. You should recognize when you should get a CT and how to go about it, and which CTs are acceptable, and why an MRI shouldn't be done. And you should be able to recognize when to call to operate and how to coordinate it. The black belt should be training you in this. And I don't care what background you are, emergency medicine, ICU, obstetrics, gynecology, orthopedics, rheumatology, I don't care. Black belts all around the world should be able to establish programs and train people very well. And they should have the answer, or try and have the answer 100% of the time. The first thing that black belts in trauma are very good at is damage control. Now, I'm oftentimes told that damage control means being fast. It doesn't. It means being short and sweet. I'm not fast. I'm very short at what I do. I abbreviate things. You do the bare minimum required to control bleeding and to control spillage. And then you come back and you fix it once the patient is physiologically better. You do the bare minimum to control hemorrhagic shock causes, whether it's taking out organs, whether it's ligating vessels, and you can ligate most things in the abdomen really and then fix them later, or put shunts through them, or whether it's handling a problem of spillage of bowel content. You should be able to deal with these things in an extremely unstable, compromised patient very calmly, oftentimes with a couple of clamps on board on the aorta and major vessels, okay? They are exceedingly rare in pregnancy, but it's been advocated for because we don't want abdominal compartment because it could affect other things, to keep the abdomen open. And this is another thing that I find we're not very good at in Kuwait. Whenever we've had to operate on pregnant women in a major case situation, which is exceedingly rare. Like I said, exceedingly rare, we're not very good at it. Our approach should be that we should be comfortable with keeping the abdomen open, vacuuming the abdomen. This is one I made earlier. The patient survived, baby survived, everybody survived, and people did well. Okay, these vac dressings are very easy to do. If anybody in your practice needs to do them, wants some advice, shout out to me on Instagram. I will always answer you. May not answer you at the time, but I'll always answer you. If you need me to come in to help out with something, I always scrub in. In fact, I love operating. I've missed it so much with COVID. Okay, I'll always be around. People like me are always going to be around. Trauma surgeons are always going to be around. Dr. Badr is probably more patient than I am when it comes to these things. The second thing that black belts are particularly good at, and I think you learn at black belt level more, certainly I did, is you're going to need to intubate early if you have a burn patient who's also pregnant. The airway edema happens like this in pregnant women, especially in the 3rd trimester. It's shocking how much froth will come out right off the bat. The airway edema and the inhalational injury, all of a sudden will happen very quickly. So have a low threshold to intubate and have a low threshold to deliver, especially the body surface area burn is greater than 50%. And the key reason here is because 70% of them, if you hit 70% body surface area burn, it's associated with a very high mortality, close to 100%, okay? Lastly, or just before last, trauma and mental health. Black belts should be able to recognize a pregnant woman having been in a car accident. There's a lot of mental health problems associated with it. I'm not saying that it's something that needs to be addressed acutely. Sometimes it's something like PTSD, which will resolve over time. Sometimes it's a lack of ability to grieve. And sometimes it's even if they survive, it's a survivor's remorse. Sometimes they feel at fault for exposing their fetus to something. Sometimes it's the family unit. Sometimes it's not even the mother. It's the sister, it's the brother, it's somebody else in the social circle that needs that support. As a black belt, you should try and get to know that, the psychosocial aspect of trauma, which we're getting better at, even as surgeons. I was very bad at it. I took a bunch of courses. I'm getting better every day. Now, in terms of how to get your education as a black belt, different institutions have taken upon themselves. I wish I had this when I was in training. The ACS Committee on Trauma will actually help you if you apply at fellowship level with 2 references to join their Future Leaders program. And they'll train you in writing guidelines. They'll train you in becoming good at education. They'll train you on how to teach in the operating room. It's an absolutely phenomenal course. I recommend it to anybody interested in trauma. And they take anesthesia, emergency, it doesn't matter. You don't have to be a surgeon. The last thing the black belt should be good at is recognizing the traumatic perimortem deliveries, not perimortem cesareans in general, just for trauma. And this is why. You have this patient and you have this problem, but you also have other problems when these 2 are combined. When you have this patient with the trauma and you have this problem, other problems are in the way. You have free fluid in the abdomen from a fast ultrasound. You have a smashed spleen. You have a lung contusion. You have an aortic injury. You have an epidural hematoma, and you have an epidural hematoma in the child with a skull fracture. This is what a high velocity ejection blunt trauma looks like 20 to 30% of the time when they're pregnant in their 3rd trimester. And these are our customers when we're thinking about perimortem cesareans and gynecology as trauma surgeons. If I don't have enough space to handle this on a slide, how can you handle it on your own? At least at black belt level, you should know that this is something that's going to be above one person handling it, one specialty handling it. This is not going to be normal for you. And you're going to need to recognize the survival rate is dictated to some extent by the trimester. The long-term deficits are as well, the gestational age, the long-term deficits are as well. But the difference of 5 minutes drops your survival from 70% to 13%. And when you look at it, you really need to, as a black belt, understand from a systolic blood pressure of 60, heart rate of 110, things aren't going to go well here. Just knowing pregnant physiology. You're going to start temporizing maneuvers, calling your team, letting your gynae team know that there might be a perimortem cesarean section, calling your surgeon, letting them know they might need to clamp the aorta. And you're going to need to figure out that there's going to be 2 teams involved. That's how things become slick. That's how they're done in 5 minutes. And the mother and the fetus survive and everything is good, or as good as it can be. Okay? You develop a hemorrhage control team and a baby delivery team. Okay? Now, here's the problem with developing these teams. The hemorrhage control team is going to be anesthesia and trauma surgery, taking the mother to the operating room eventually. The delivery team is going to perform the laparotomy, deliver the baby, and hand it over to the NICU with the NICU expertise. And the final destination for both, we hope, is going to be the ICU or the NICU. Every single brown box that you see here is an attending at this point, because this is a very, very difficult problem. Just getting the patient positioned for CPR with adequate access will require a team of 4 people. And so the question becomes, how do we coordinate this? At black belt level, you recognize that you need the trauma team leader at some point, and that the trauma team leader is not going to do anything with their hands. They're just coordinating 4 different attendings, 4 different domains that are encapsulated in one huge problem. Experts learn how to work in synchrony with a clear command structure and with oversight over each other, have each other's backs. They all have their own domain, but they integrate so well that you don't even feel like they have their own domain and that they have domain ownership. They look like they've been working together for years and years and years, even though they haven't. How well you integrate with your hospital and the rest of your team. You can be assertive. Everybody knows that I'm extremely assertive in the trauma room. I'm not a nice guy, but you have to learn how to integrate. When you do that, you will have a parallel set of teams in perfect synchrony with the delivery decision being made, the hemorrhage control team activated, a thoracotomy being performed, but no clamp because you don't want to compromise fetal circulation, a laparotomy being performed. Subsequently, once obstetrics say clamp the cord, my clamp goes into the chest. And then I get a systolic that's beautiful, but I've restricted the flow to the abdomen. I then rush my patient with anesthesia to the operating room and do the best that I can for the mother. And then I blank out, that's it. I'm not looking at anything that happened in the trauma bay. I'm not discussing the shouting. I'm not discussing anything. That's what black belts do. They learn how to work together in a team and integrate. So I think that I got through everything. I apologize if I went a little bit over time. I really tried not to. And in conclusion, if I were to give you one piece of advice, a healthy mother equals a healthy baby. Don't compromise one for the other. Do your best for both. And accept morbidity over mortality. You're not going to be perfect. For those of you who are outside the realm of trauma, I want you guys to join my trauma army. Trauma cannot be built by trauma surgeons alone. We just can't do it. It's not ingrained in us. We don't have the patience. We don't have the skill set. Trauma is extremely complex. And to prevent every single the preventable death, I need you guys with me. Thank you for your time. And feel free to subscribe to my iTunes stuff. Every now and then I put something that's relatively interesting. And if you have any questions, I'm available on Instagram. Okay.
Thank you, Dr. Saud, for such a wonderful session. Very well presented. And I'm glad today that I have reached the blue belt level for now, if I'm not mistaken, but I'm aiming for the black one. So.
A good blue belt.
Yeah. So just a reminder for the audience, if you have any question, you can send it in the question and answer section because the chat is closed. And now we will move to Dr. Jihad, and she will be talking about perimortem cesarean section. Okay, Dr. Jihad, you can unmute yourself and share your slides.
Well, good afternoon, good evening, everybody. First of all, I would like to thank the organizers for inviting me to participate. And then I'd also like to thank Dr. Saud for a very comprehensive and interesting presentation on trauma and pregnancy. I'm glad I made the decision to deviate a little bit from the subject because I don't think I can add much after this presentation. So I will just start with an outline of what we're going to talk about today. I'm going to start with some introductory remarks regarding perimortem and postmortem cesarean sections. Then I chose to talk a little bit about the most common indication for perimortem cesarean section, which is sudden cardiac arrest, which includes trauma as one of its causes. Then I'll spend just a few minutes talking about CPR during pregnancy and what are the things that are different about delivering CPR to a pregnant patient versus a non-pregnant patient. And then I'll spend most of the talk talking about the perimortem cesarean section itself. So it's very interesting that the postmortem cesarean section is one of the oldest described surgical procedure in the literature. A perimortem cesarean section is defined as a surgical delivery of the fetus that is performed either at or near the time of maternal demise. And when I did the literature review, I found many references to postmortem cesarean section in Roman, Greek, Egyptian, Hindu, and Persian mythology. It is referred to many times as an immaculate birth, and it's described as a birth of the fetus through the maternal abdomen or the maternal side. And it's usually described for gods, demigods, and heroes, because it was considered that these individuals, the fetuses that survive after the death of their mothers, are somewhat blessed. The earliest report of a post-mortem cesarean section in the modern literature was from Switzerland in the 1500s. And interestingly, that mother survived The other early report came from Britain in 1738. The report from Switzerland was performed by a butcher on his wife. The report in Britain in 1738 was performed by a midwife. Unfortunately, that mother died about 2 or 3 days after the delivery of her child. It's interesting that in the 17th and 18th century, post-mortem cesarean sections became a requirement by the law. And it's also interesting that one of the few incidences of a physician being litigated and actually sentenced to death was in Sicily in 1747, and it was for failure to perform a post-mortem cesarean section. If we take the point of view of religions, post-mortem cesarean sections are mentioned in Jewish, Catholic, and Muslim literature. And actually, the first known illustration of an abdominal delivery, which dates to 1307, was by Al-Bayruni and his book, The Chronology of Ancient Nations. And it was most probably a post-mortem cesarean section. So post-mortem cesarean section is one of these situations that are really very anxiety-provoking for the healthcare delivery team, and there's a lot of hesitancy surrounding it. It's a rare occurrence. I have personally never performed a peri-mortem cesarean section. It would be interesting later on to see if anybody in the audience has witnessed or participated in a post-mortem cesarean section. I've been an obstetrician for more than 32 years, and I haven't had the chance to do that. The other aspects that raise a lot of anxiety is that most guidelines out there regarding peri-mortem cesarean section are based on case series and literature reviews, because that's the best thing that we have. If we look at the quality of the evidence in a literature review that was published in 2012, the authors collected more than 1,500 cases from 1980 to 210, but then included only 94 cases because relevant information was only obtained in these cases. So that gives you a lot of hesitancy regarding the level of evidence that we have out there. Another anxiety-provoking aspect is the lack of training in post-mortem cesarean sections. Although there have been more and more reports in the literature about models and high-fidelity simulations which can be used as teaching and training modules for post-mortem cesarean section. An interesting report came from the Netherlands in 2004, which showed an increasing use of post-mortem cesarean section after an introduction of the MOE course. Although when they did look at the outcomes, it seemed that there was a delay in the performance of the peri-mortem cesarean section, and the outcome was not as good as it should have been. So it seems that even when training has been given, still there is a lot of reluctance and hesitancy in carrying out post-mortem cesarean section. Fear of litigation is another one, and there are many ethical, medical, legal, and psychosocial issues. However, I will strive to show you that what you are doing when you're doing a peri-mortem cesarean section is something that has a good chance of helping mother and fetus and almost zero chance of harm. The confidential inquiry into maternal deaths in the UK looked at a review of peri-mortem cesarean sections for over 25 years, and they concluded that no babies that survived beyond early neonatal period had a significant neurological disabilities. And they reported that there was intact fetal survival, or I should say neonatal survival, even when the cesarean was done 25 and 47 minutes after the mother was declared dead. So this is going to give us a different mindset about the timing of the perimortem cesarean section. As far as I could search this literature, I could not find any documented cases of litigation for any healthcare provider for performing a postmortem cesarean section, neither in the United States or in the UK. And usually consent is not an issue in these situations. It's a high-risk situation and you're doing a procedure that is life-saving. So let's talk a little bit about sudden cardiac arrest in pregnancy. That's another rare occurrence with variable incidence, anywhere between 1 in 20,000 to 50,000 ongoing pregnancies. Reports from North America are very similar, 1 in 12,000 hospitalizations for delivery from the USA and 1 in 12,500 from Canada. The numbers that come from the UK are a little bit less, 1 in 36,000 maternities or pregnancies. So it is a rare occurrence. The most common causes are pulmonary embolism, which accounts for about 1/3 of the cases, followed by hemorrhage, sepsis, peripartum cardiomyopathy, stroke, preeclampsia and eclampsia, anesthesia complications. Additional causes are amniotic fluid embolism, myocardial infarction, pre-existing cardiac conditions, and trauma. It's very interesting that more than 60% of pregnant women who have a sudden cardiac arrest are obese. And that's going to make things difficult because of technical aspects as well as the presence of multiple comorbidities. So for the resuscitation of a pregnant woman who has sudden cardiac arrest, we're going to call a maternal blue code. The multidisciplinary team must include an obstetrician and neonatologist. Okay. If you have a few minutes or seconds to ask about anything, there are 3 questions, the answers to which may help you during the resuscitation. It's the number of fetuses that the woman is carrying, the gestational age, and if she's on any medication that's likely to interfere. So for the resuscitation, we have to remember the following. Manual displacement of the uterus, and I'm going to talk about manual displacement versus tilting the mother during CPR. High quality chest compressions. How do you deliver high quality chest compressions during pregnancy? The use of a defibrillator and medication, IV access, end-tidal CO2 monitoring. You have to have a dedicated timer when you are carrying out a maternal code blue, because that person is going to tell you when it's time to consider the perimortem cesarean section. As Dr. Saud referred to, it's the 4th minute rule. At 4 minutes, you have to think whether or not it's time to get this baby out. So usually, if you've been resuscitating a pregnant woman for more than 15 minutes, then it's time to consider going for direct cardiac massage. In certain cases, a thoracotomy and open chest massage may be preferred, such as cases of chest trauma. If you suspect or know that the patient has a tension pneumothorax, a massive pulmonary embolism, pericardial tamponade, or chest or spine deformities, because the thoracotomy is going to give you a chance to deal with these things at the same time. Sometimes, rarely, you may have to consider a cardiopulmonary bypass. So for the airway, there are more than 2 approaches. The primary management is a bag and mask that should be followed in most cases by intubation. As Dr. Saud said, women in the 3rd trimester usually have edema of the upper airways, even if they are otherwise normal. So this problem is magnified if the patient has preeclampsia. So usually your primary management is going to help you in just a proportion of cases. You need to be able and ready to go to your secondary management if the primary management does not give you adequate ventilation. So we should always begin with bag and mask ventilation. Use 100% oxygen at 8 to 10 liters per minute using a two-handed technique. You want to deliver about 15 liters per minute. This should be followed by suction of the upper airway. Again, these women have a lot of secretions. Then video laryngoscopy is usually the best way to go. Use an ETT that is 0.5 to 1 millimeter less than you would use in a similar adult that's not pregnant because of the edema. Capnography is a must. It's very controversial whether the use of cricoid pressure in pregnant women is helpful. It may be tried, but if it seems to be obstructing the view of the person who is trying to intubate, it should be abandoned. Usually the recommendation is to try to intubate twice. If not, then you go to the secondary management, which is either applying a laryngeal mask or a cricothyrotomy. When you are ventilating a pregnant woman, you have to be cognizant that because the diaphragm is elevated and the chest compliance is decreased, I apologize for the typo, you need to use lesser volume. So you need to use about 350 to 500 cc's rather than the 600 cc's that's recommended in adults. Also, you have to avoid hyperventilation. Normally, pregnant women are in a state of mild respiratory alkalosis because they have a higher PaCO2 and a lower PaCO2. And that's how the gas exchange occurs from fetus to mother at the fetal-placental interface, the placenta. But if you overventilate a pregnant woman and you have non-physiological respiratory alkalosis, that tends to cause uterine vasoconstriction. And if the pregnancy is ongoing, if the fetus is still in utero, that's going to mean fetal distress, fetal hypoxemia. Chest compressions, it's been described that the best position is supine with manual uterine displacement by another provider. Usual hands placement, the idea that you have to place your hands a little bit higher is not valid anymore. This has been demonstrated in studies using MRI that show that the position of the heart is about the same even in the third trimester of pregnancy. So you don't need to change the placement of your hands on the patient's chest. Use 100 to 120 compressions per minute. And with each downward stroke, you should have about 5 to 6 centimeters. IV access, at least 1 and preferably 2, if you can manage. Using the antecubital vein 14 gauge is good enough. A central line will just provide one more advantage, is you can do hemodynamic monitoring, but in the first few minutes, a line in the antecubital vein is fine. If you can't find any IV access, intraosseous access may be used. And remember that there are some medications that you can apply even through the ETT, like lidocaine, atropine, epinephrine. Now, how do you avoid aortocortical caval compression? This is a big problem. Whenever you have a pregnancy in which the uterus, the fundus of the uterus, the top of the uterus, is at or above the umbilicus, and this is regardless of gestational age. This is a problem of mechanics. It's the size of the uterus rather than the duration of pregnancy that is the key factor here. So if you have multiple gestation, or if you have a uterus that is big because of other factors, such as the presence of fibroids, you're going to have the same mechanical effect. You're going to have aortocaval compression. So what's recommended is manual displacement of the uterus by pushing on the right upper border of the uterus towards the left. You want to get at least 3 to 4 centimeters of deviation of the uterus from the midline. And this has been found to be superior to tilting the patient. O'Connor reported a very elegant study that was done in 1994, in which they used a calibrated force transducer to assess the maximum force generated at various angles. If the patient is supine with a left tilt, then you get 67% of the body weight. If you tilt the patient 27 degrees, which is the recommended, you'll get about 57%. That's 80% less than what you got with the supine, with the manual displacement of the uterus. If you go to full lateral, you are only getting 36% of what you should be delivering. So the recommendation has changed from either a left lateral tilt or supine with manual displacement to supine position with manual displacement. If you are going to shock a patient because she has a shockable pattern and the patient is in labor, so there are CTG, cardiotogography, the fetal monitor is on, especially if it's a scalp electrode, an internal monitor, then you should remove it, okay? And everything else is the same. You use the same energy requirement and you increase as needed. There are no restrictions for the use of any medications that are required for CPR during pregnancy. Whatever you use for any non-pregnant patient, you can go ahead and use it during pregnancy. Now, fetal considerations. Determining the gestational age is sometimes not something that we have enough time to do. If you don't have access to the medical record of the patient or a family member or companion who can tell you how many months she is, then just go by the fundal level. As a rule of thumb, when the fundus is at the umbilicus, this is about 20 to 22 weeks of gestation. The ultrasound is usually you don't have the luxury of time to do an ultrasound in order to determine the gestational age. In best hands, that takes about 5 minutes because you have to have at least 3 parameters measured in order to define the gestational age. So forget about doing an ultrasound just for determination of gestational age. Fetal heart monitoring, again, is not a requirement in the setting of sudden cardiac arrest during pregnancy because the management is guided by the maternal status rather than the fetal status. In this setting, you should think of delivery as part of the resuscitation process. The recommendation is to commence within 4 minutes of cardiopulmonary collapse and deliver the baby within 5 minutes. So you have 1 minute to perform the perimortem cesarean section. If the patient is in labor, remember to check if she's fully dilated. You may be able to effect the delivery faster by the use of a vacuum extractor or forceps. For sure, you have to do a pelvic examination in the setting of a patient who is in labor. Now, what's the rationale for the perimortem cesarean section? First, by evacuating the uterus, you're going to make the resuscitation efforts, the CPR efforts, much more easier. You're going to decrease aortocaval compression. You'll stop the uteroplacental blood flow, and then the blood that was flowing through the placenta is going to be auto-transfused to the systemic circulation of the mother. And there are multiple studies that document that the stroke volume immediately improves following delivery of the fetus in a mother who is in the setting of cardiac arrest. Are there any contraindications to performing a perimortem cesarean section? The only one I can think of is a mother who has regained spontaneous circulation. According to the guidelines from the American Heart Association, after 2 cycles of CPR, which is about equates to 4 minutes, if the mother has not regained spontaneous circulation, you should consider going for a perimortem cesarean section. Now, the timing, the 4-minute rule has been documented again and again in multiple studies. This is a study that comes from the UK, from the UCOS, the UK Obstetric Surveillance System, which is a very interesting system that reports and follows many rare conditions that occur during obstetrics and gynecology. So they reported on 66 cases of sudden cardiac arrest and 49 perimortem cesarean sections. They reported 46 live births. 32 of these babies were born to mothers who survived and 14 to women who later died. It was very striking that the time from collapse to the performance of the perimortem cesarean section was significantly shorter in the mothers who survived. So with a median of 3 minutes versus 12 minutes. So if you're trying to save the mother, 4 minutes is your aim. In another review that looked at 54 perimortem cesarean sections, it was very interesting to find out that in about 1/3 of cases, the perimortem cesarean section was beneficial to the mother. And there were no cases in which it was thought that any harm came to the mother because of the performance of the perimortem cesarean section. Neonatal survival, which is the other thing that you're always looking at in this situation, was 64%. And again, significantly shorter time in the survivors versus the non-survivors. So for neonatal survivor, the mean time to from arrest to delivery was 14 minutes compared with 22 minutes for non-survivors. Katz performed 2 very interesting literature reviews some time apart. He looked at the outcomes from perimortem cesarean section in 2 periods of time, and he reported on normal neurological outcomes in the neonate. And you can see from the table that neonates that were delivered within 5 minutes always do much better than neonates that are delivered later than 5 minutes. And in the second review, he also looked at maternal survivals, and he noted that 12 out of 20 mothers had return of spontaneous circulation or improvement in their hemodynamic status when the perimortem cesarean section was performed within 5 minutes. Having said that, it seems that there is a lot of reports in the literature, very interesting reports, about perimortem cesarean sections that were performed much longer than the 4-minute rule. And they had relatively favorable outcomes. So a report from Italy in 2007 on a mother who jumped from the 4th floor during labor to commit suicide. And the cesarean was done 30 minutes after she was proclaimed dead. The baby was normal at the age of 4 years. Another report from China in which they reported a perimortem cesarean section done 43 minutes after collapse of the mother secondary to a motor vehicle accident. The mother was discharged with only a mild concussion. However, the infant had moderate cerebral palsy at the age of 7 months. So ACOG recommends that even if the 4 minutes have passed and the patient has not regained spontaneous circulation, it is still a good idea to perform a perimortem cesarean section on these mothers. The minimum gestational age is quite controversial. Usually the accepted range is 22 to 24 because most facilities that have a good neonatal intensive care, they have very good survivals for babies born at 22 to 24 weeks of gestation. Remember, when you are trying to resuscitate the mother, it's the uterine size. It's not the gestational age, it's the uterine size. That's the more important factor. Usually there's no time to transport your patient to the OR, so you need to be ready to perform the hysterotomy at the site where the mother collapsed. Subsequent closure may be carried out in the OR. Remember that the equipment you need, you're going to need equipment for three things: maternal CPR, performing the cesarean section itself, and neonatal resuscitation. So every emergency delivery kit should include a cesarean section kit, and this should be available wherever you might see a pregnant woman in cardiopulmonary arrest. Of course, you're going to do a laparotomy as fast as you can. The recommended incision is a midline vertical incision. You can either do an incision from the civis-sternum to the symphysis pubis, or you can start at the fundal level and go down to the symphysis pubis. Once you have reached the uterus, the recommended incision is a low vertical incision on the uterine corpus. The problem that you may see there is that you didn't have time to empty the bladder. So either you will retract the bladder with a retractor, or you may quickly empty the bladder with a needle. Deliver the baby as quickly as you can, then clamp and cut the cord and handle the baby to the neonatologist. You may want to deliver the placenta quickly and then just pack the uterus in the abdomen. There's no time to close. Think of giving the patient antibiotics because they will, if they survive, they will be at high risk for sepsis. The recommended are either broad-spectrum penicillins or a first-generation cephalosporin. And you want to give uterotonics. You want the uterus to contract. So either give syntocinon as a dilute IV infusion or directly into the myometrium. The complications that you have to think of are a bladder injury, fetal injury, so be careful when you're opening the uterus. You can avoid major vascular injury when you go in the midline because the incision is not going to extend laterally. You will find yourself sometimes in a high-risk situation, like a patient with previous cesareans, a placenta previa, multifetal gestation, and morbid obesity. Unfortunately, in our current practice, patients with one or more of these complications will make up about 75% of our population. So you're very likely to encounter one or more of these. Post-arrest, if the patient makes it, you're going to go to the ICU. Again, you need left lateral tilt because the uterus is still big and may compress the IVC or aorta. The other thing that you have to think about is the lability of the core temperature, which occurs after sudden cardiac arrest in many cases, and it's associated with increased mortality. You have to avoid hyperthermia, and you may, in some cases, especially in mothers who have already been delivered, think of therapeutic hypothermia. It's not something that has been studied very well during pregnancy, but after delivery, mild to moderate hypothermia has been reported to be beneficial in patients who are comatose or not following commands or having purposeful movements after being resuscitated from sudden cardiac arrest. Now, sudden cardiac arrest in pregnancy has high mortality. 30 to 80% of the mothers will die, and high neonatal mortality, almost 60%. Morbidity is also significant. 12% of maternal survivals may have poor neurological outcome, as well as about 21% of the babies may also have the same. Favorable outcomes are usually determined by the underlying etiology of the cardiac arrest, the location of the arrest. So patients who arrest in hospital usually do much better than those who arrest prior to arriving in the hospital for obvious reasons. The speed of resuscitation and the skills and the resources available at the center where the mother arrested and was resuscitated. Interestingly, patients who have complications from anesthesia tend to do the best because they usually arrest either in the OR or in the presence of an anesthetist, and that's why they compare so favorably with other etiologies. When a comparison was made of survivals of sudden cardiac arrest in pregnant women versus women who are not pregnant but are of reproductive age, women who are pregnant tend to do much better. And it's because usually the underlying cause is something that is more reversible. Now, I thought it would be very good to try and think about how we can enhance the outcomes of healthcare teams in our situation. In Kuwait, we have an unfortunate situation because the largest maternity unit, which is a maternity hospital, is a standalone OBGYN hospital. So if a patient has sudden cardiac arrest and it's something that's not related to pregnancy, like trauma, she's not going to fare that well because we have to call in other experts. The other poor outcomes may be seen in general hospitals that receive trauma patients and don't have an obstetrical department. And unfortunately, we have 3 major hospitals, Sabah, Amiri, and Mubarak, that have trauma patients, and there are no obstetrical units or neonatal units. So that may be something that is worth thinking of for people who make policies for delivery of healthcare system. Having a clear hospital policy and guideline for resuscitation of pregnant women who have cardiac arrest is another thing that is going to improve outcome. Training and simulation, especially in the multidisciplinary approach. So training multiple healthcare providers of different specialities and simulation that has been shown time and again to actually improve the healthcare outcome. And with that, I come to the end of my talk, and I give the podium to the moderator, Dr. Zahra.
Yes, Dr. Thank you, Dr. Jihad, for such a great session. It was very informative and very well presented. And now we will move to the last part, which is the question-answer part. As we're running short of time, we will take only 1 to 2 questions for now. If anyone has any other questions, you can just send your question by email. So the first question is from Dr. Mariam Darwish. Medically, can trauma surgeon perform the cesarean section if the obstetrician is not available in the time frame? I think this question can be answered by Dr. Saud Zaid or Dr. Jihad Al-Harami. So, Dr. Saud, you can unmute yourself if you're happy to answer the question.
I think
Dr. Jihad as well.
From both perspectives, to be honest. Hello, can you guys see me and hear me? Yeah.
Yeah.
Okay.
Yes.
So I think that Dr. Jihad, if you don't mind, I think for educational purposes, and I'm pretty sure that you agree, we're on the same page on this, we should probably both answer from our perspectives. I would say you have to assess your situation. My understanding is that ethically, first off, you're asking a very complicated question. You're not asking me if you're going to get investigated. You're asking me if it's medical legally a problem. Okay. From our perspective as trauma surgeons, medical legality and investigation aren't a big deal because we know that it's inevitable. Our outcomes aren't always great. And we know that it's devastating for families. And so we accept it as part of the burden of the specialty for us. And I'm pretty sure that in obstetrics, it's the same. And so, you know, for me, it always goes back to, does the literature support what you're going to do? Have you been trained in it? And can you do it to save a life? And if you delay it, هل أنت راح تدان? Or are you going to be implicated in the mortality? So as somebody who was trained in general surgery, who's actually been involved in a couple of perimortem cesareans, which I can't go into if we have enough time, but it's superfluous at this point. I think Dr. Jihad explained the situation pretty well. Particular to trauma, the time that I'm thinking of doing the perimortem cesarean is the same time that I'm putting in an aortic clamp, which is the same time that I'm considering a laparotomy. So it's not a huge thing for us to extend that, technically. And a lot of trauma programs will make you rotate on certain services that help you extend that, like rural medicine or rural surgery, where you are expected to learn how to do cesareans because you're working in the community. At least that was my training at some point. And so I think that's why I think I'm a little bit more comfortable with it. I do know that there's a lot of trauma surgeons who don't do them and can't do them and have a fear of making that decision, right? So I think if it's justifiable, if you can prove that you did it in your training, and if you're going to save a life with it, you can go ahead. But know that you may be investigated. And so to cover yourself with an investigation, I'm preparing a talk about this for against medical advice discharges. To protect yourself is first to document, second to document the rationale, third to document the indication, and fourth, to make sure that you can at least maintain a standard of care, especially when you know that obstetrics isn't available in your institution. As Dr. Jihad said, we're in a very difficult position in Kuwait. The best place to save a mother and a baby is also the place without the trauma surgeon, and without the cardiologist, and without interventional cardiology, and without ECMO, right? Without the options that will produce maximal outcomes. The best place to save a trauma patient is not here. We don't have a dedicated trauma center yet. We will eventually get it. I have faith that there's going to be some public or some professional discussion whereby we eventually work together towards that goal. I think it's a very important thing. It's the second biggest killer in Kuwait. Trauma is the second biggest killer in Kuwait. And so I think that will happen. But even when that does happen, how realistic is it that I'm going to have a fetal-maternal specialist or maternal-fetal specialist whose main practice is high-risk stuff, dedicate themselves to working with us, training us, being around in the current working environment? And so you do have to consider that you will have to do this procedure. You will have to take care of pregnant trauma patients, and you'll have to do it pretty well. Now, the enemy of good is perfect, right? You should never strive for something that you're not. I know I'm not going to be a good obstetrician ever. I know that I can't do a very good fan and steel. I try and do them for colorectal laparoscopic stuff. It's very challenging for me because I'm never really comfortable with the exposure. I'm used to huge laparotomies and thoracotomies, right? But if you're going to save a life, it's worth the risk of getting investigated and sued. That's my logic personally. I know it's a complicated answer, but it's the best answer I can give you. If you can save a life, it's worth that you get sued, in my book, ethically. And if I can justify it ethically and document it correctly, in my book, it's the right thing to do. What do you think, Dr. Jihad?
Well, I totally agree with you. In our situation, we're not likely to have a team that's going to have an obstetrician in a trauma patient. So the person with the most expertise on site is the person who should perform the perimortem cesarean section. Now, there are a lot of reviews in the literature and case reports of perimortem cesarean section being carried out by paramedics, especially those who do AirVac. And the outcome is not dismal. The outcome is at least comparable to outcome that is done in hospitals when the perimortem cesarean section is delayed. So I think the perimortem cesarean section that's done by the most experienced person on site is better than not doing the perimortem cesarean section. And as I said, there are no reports that there can be any harm from doing a perimortem cesarean section to the mother. Okay, it may be beneficial in up to 1/3 of cases. So I don't think that there should be major medical legal issues about who's performing it.
Okay, so we can move to the last question. In case of maternal compromise, does the exploratory laparotomy precede the cesarean section or the other way around? I think also this can be answered by either Dr. Saud or Dr. Jihad.
Okay, so another very good question. I would contend that it depends on whether your patient is unstable or agonal, and fetal viability or fetal distress. Those two are the major factors that at least trauma surgeons look at. Okay. In my particular case, it just so happened that the few times I've done it, like maybe 4 times, witnessed it once. 2 of them didn't go very well. The other 2, one of them, it just so happens that the patient was hemodynamically stable, but with a penetrating injury to the anterior abdomen. Those go straight to a laparotomy. We don't wait on stab wounds. Like I said, any penetrating injury to the abdomen, it's a high mortality risk situation, pregnancy. And so when we did the laparotomy, we found that the uterus had actually been injured by the gunshot wound. And the decision was made by the obstetrician involved to perform, because the patient was agonal at that point, and we had aortic clamp on, to perform a perimortem in the context of an initial exploratory laparotomy in which we had profound bleeding for multiple areas. So I would say if your patient is unstable but not agonal, the laparotomy can supersede, and just like the picture that I showed, you can vac the abdomen and you can assess for fetal viability. If your patient is agonal, you don't have a choice, especially with hemorrhagic shock. You really have to understand, for a pregnant woman to get hemorrhagic shock, it's a big deal. It takes a fair amount of bleeding for that to happen in the context of trauma. And it's going to be multiple areas of bleeding. And so we don't like to wait if the systolic is 60, really. We tend to push a little bit more. What do you think, Dr. Jihad?
Well, I agree with you. Highly individualized, depends on the nature of the trauma, the size of the uterus, and whether or not the mother is stable or, as you said, agonal. So it's not something that can be discussed without full details of the case.
Okay. So I think that brings us to the end of the session. Thank you, Dr. Saud and Dr. Jihad, for your time, and thanks for such a wonderful session. I think it's highly important to understand what do we have to do when we see these trauma cases, especially in this group of patients, as I believe that it's common that we see these patients and run into this age group. Thank you, everyone who joined this session. Thank you for your attention. This session is recorded and it will be uploaded to the SurgiQ8 platform soon. And stay tuned for our upcoming events. Thank you so much. Thank you, Dr. Saud. Thank you, Dr. Jihad.
It was a pleasure.
Thank you.
Everybody.
Thank you so much.
Hope to meet you one day, Dr. Saud.
Likewise.